So now I'm excited to introduce our speaker. Dr. Taylor Manalili is the Director of Clinical Prosthodontics here at Glidewell Dental. She plays a vital role in enhancing laboratory protocols, conducting clinical research, and performing advanced restorative work. Her expertise includes implant placement, chairside restoration, and full mouth rehabilitation. She received a bachelor's degree in chemical engineering from Northeastern University and her DDS from Stony Brook University, where she also obtained an advanced certificate in prosthodontics and digital technologies. Her accomplishments include completing a fellowship and diplomat in the International Congress of Oral Implantologists and is a prosthodontic faculty member of the Resnick International Implant Institute. Dr. Manalili has over 10 years of teaching experience in multiple and diverse educational settings. I've had the pleasure of working with Dr. Taylor for a couple of years now, and it's really clear that she's passionate, she's intentional, and she's committed to educating others in an easily digestible manner. So without further ado, I'd like to turn the spotlight over to her.
My goodness. Thank you, Nicole. It's very flattering.
Thank you.
I appreciate that. Happy to be back here. It's been a while since I've been on here. Let me go ahead and share my screen. For those of you that don't know me, like Nicole said, I work here at Glidewell. If you've come to any of our symposiums in the last year, you probably saw my pregnant belly last year. For a moment, you will get a glimpse of my twins that I had in October. This is Charlotte and Jackson hanging out. And now I'm going to share hopefully the right screen. Let's see. There we go. All right. Cool.
Perfect.
Okay. So what's the most stressful part about this? Okay. All right. So thank you guys for joining me today. We have about 40-ish minutes to get through this amazing topic. So I don't know exactly who's in our audience today, but whether you're a restorative doctor that you work with a surgeon or you happen to place your own implants and then restore them yourself, if you're not doing guided surgery, I think some aspect of guided surgery is definitely going to appeal to you. For those of you that may be dabbling in guided surgery or do guided surgery, hopefully there's a couple tips or tricks you might learn today. So this obviously is a very large topic. So I'm going to try to touch on as much as I can, but this is a webinar. We do full day courses and things here at Glidewell that we do go into a little bit more detail. But without further delay, let's kind of dive on in. So let's see if I can figure out how to move forward is the next part about this. Here we go. So freehand versus guided, right? So I was asked to first kind of talk about why do we want to do guided surgery, right? So when I first started placing implants a while back, maybe about 15 years ago now, I started doing freehand surgery, right? I started assisting in freehand surgery. I started watching freehand surgery and then doing it myself. So we have these two options now. So freehand surgery, I think, is a must. Understanding the principles, how to bail yourself out if you need to, that does not change, right? So I think there are advantages and disadvantages to each of these, right? So, and it's important to really consider both when we are deciding which type of surgery is really best for that particular patient. So this is kind of the analogy I quickly just want to touch upon. So if someone's seen me lecture, you may have heard this analogy already, but it is my favorite analogy. So I'm sure everyone or most of you in this webinar today have gone on a road trip, whether it's by choice or maybe a family road trip many years ago. But typically when you go on road trips, at least when I was a child and when I was younger, right, we had to plan for those road trips. So my dad would pull out something like this, right, a Rand McNally map, or he would call AAA and get like the map ticks, right? And we would figure out and kind of map out our route. So we would follow along as we drove. We would consistently be checking. They would always give me the map and I'd have to follow along. And it was kind of a little stressful, right? It was as you went along, you were hoping and praying we didn't miss that exit. You really had to plan and navigate in real time. And I kind of look at this as kind of freehand surgery, right? So not that we can't do it. We know all the anatomy, we've studied, we understand what we should do, where we're going. But we still have to pay very close attention every step of the way, right? We really have to understand the basics of how we're going to do this freehand surgery. So, freehand surgery is typically performed with the help of, right, this predetermined plan, right? So we have mapped out our plan, typically with the support of some sort of imaging technology. So nowadays, used to be like panoramic images many, many years ago. Nowadays, CBCT, I recommend if you don't have one or you're not using one to place implants, definitely start doing it. That is kind of rule of thumb now legally. I don't even know how you would skirt around not having a CBCT if something went wrong, right? It's really nice. It gives us that 3D perspective. You can see all the anatomy, all the danger zones. You can really plan out thoroughly where you want to place that implant and visualize that outcome, right? Freehand surgery has some advantages over guided surgery, right? These include kind of increased flexibility. So if you decide you need to change something in real time, it allows that ability to do so. Right. So there are systems now that kind of combine both of this, right? You can do guided, some of these like Navident systems guided, but you have the ability to do freehand. I don't know if anyone's tried those. I've tried them. I was not a gamer growing up, so it's very challenging for me to use. But technology is ever expanding. So it's getting more and more interesting to see where life is coming, right? Life is going. So with this ever kind of evolving technology, I think guided surgery is a much more predictable and safer way to do things. So this was an implant, right? I mean, I placed this implant, right? So I placed this implant freehand. It looked beautiful clinically when I was doing it. When it comes time to restore this implant, you can see it's maybe not in the most ideal position, but visually when I'm placing this implant, and this is a very typical spot I will typically do freehand surgery, right? Because it's really hard for the patient to open up so wide. Um, you could see I still kind of missed the mark just a little bit, right? It's not totally off, but we still have our screw retain restoration exactly where we want it, but we have a little bigger of a mesial cantilever than I would have liked. So down the road, we have to make sure the patient's keeping it clean, review oral hygiene. Down the road, I'm going to be worried about that tooth in front of it, watching it for caries, things like that. So necessary skill, but it definitely has some disadvantages. Okay, I want to take a minute to go back to this road trip analogy. So, favorite, I was asked like a couple of years ago, I was in some symposium and they were like, "What is your favorite app?" And without even blinking an eye, this app came to mind. So, Google Maps is my favorite app. I do a lot of traveling and a lot of trips and I love it because you can mark places you've been, you can mark your favorites, you can mark places you want to go, places maybe you don't want to go. You can label things. So I kind of view Google Maps as it allows me to visualize my entire trip, right? So I can plan the route exactly the way I like it. I can highlight all those important stops along the way. And I really feel like this kind of embodies how I feel about guided surgery, right? So ahead of time, I can plan out exactly where I want that implant, exactly how I'm going to put that implant in. I can pinpoint and highlight some of that vital anatomy that may be points of interest. I can avoid it if I want to, and understand ahead of time those areas that I want to avoid, and then the safe places that I actually can place that implant, or even some of the things I may need to do to better prepare for that journey, right? So 100% I relate Google Maps to guided surgery for all of these things, right? So I get to where I want to go in a much more predictable manner. And I know all of this before I physically even touch the patient. So just like Google Maps, right? You know your exact route, all the places you want to go. Um, there's always surprises, which I say you need to understand exactly what you're doing before you place your implants. But for the most part, there's very little surprises, right? So I know my surgical plan, and most importantly, I understand my restorative outcome when I do my surgical plan. So, as a restorative doctor, I love this. I love being able to plan exactly where I want my implant. I understand exactly how far away I am from that vital anatomy. I use the very stable surgical guide to place my implant exactly where I planned it. And then I have this beautiful final restoration exactly the way I wanted it to look. Right. So very, very comforting for me as both a surgeon and a restorative doctor, right? Because at the end of the day, I own that. I own that case. I own that restoration. And this is something, if you do work with a surgeon, that you need to start treatment planning these cases, even these simple cases with your surgeon, because I don't know, as a prosthodontist, I get referred all sorts of fun cases, and a lot of times they're just these cases that doctors keep trying to fix a restoration over and over and over again, and it's really nothing they did. My lights went out. Really nothing they did personally, but maybe the surgeon placed the implant in a slightly off angle position, and now it makes it a restorative nightmare, right? You keep having to fix something every 6 months or every year, every 5 years, something's going on, right? So we want to minimize that and have the best possible patient outcomes and the best patient outcomes for your own practice. Okay, so we have partially versus guided surgery. So I want to, or fully guided. So partially guided versus fully guided. I just want to touch on this quickly. So with partially guided, we're mainly using something called like a pilot guide. So, or a guide that's going to take you part of the way there. So when I first started doing guided surgery, this is something that I got into, and I started doing this quite a bit. I loved it because it started my initial osteotomy. It gave me kind of the initial angulation, placement, exactly where I wanted it to be based off of a tooth position this is when I used to like wax up my teeth, right? And then I'd create some sort of surgical guide that I would then drill holes in. That would be my pilot guide. Typically, that when you look at these guides, they do have drill stops, different millimeters in length. They typically only go from about 1.5 to 2 millimeters in diameter. For most of these, again, these are just kind of initial osteotomies to get you going. So a great thing, better, in my opinion, better than complete freehand surgery. But again, still, it's limiting. There's still a lot of surgical risk that you are taking when you do something like this. For fully guided, so this happens to be the Glidewell HT system, formerly known as the Han system that I'm showing here today. So systems that are fully guided like this are going to engage, so each drill will engage the surgical guide fully throughout from your pilot hole all the way through your final implant placement, right? So all the way through the entire sequence of the drill, you are using the guided surgical kit along with the guide to fully place that implant. So a lot of advantages to this, right? So everything's performed through the surgical guide. So like I said, you kind of map it all out ahead of time, and it makes the implant placement quite predictable, quite easy. So a lot of the planning is ahead of time. And then the day of surgery, it's very easy and very predictable, very quick chair time, which is what we like, right? We want to maximize our chair time, like Dr. Levin was just saying. So different kinds of surgical guides. So we can do anything nowadays. Technology is wonderful, right? We can do tooth-borne surgical guides, mucosa-borne surgical guides, and then bone-borne surgical guides. So these are the three major types of guides that are out there that can be fairly reliable for you to place your implants. And I'll give you kind of my view on these three. So when you have stable teeth, obviously studies have shown overwhelmingly that tooth-supported guides are going to be your most accurate guide. So if you don't do guided surgery yet, this is where I would start. And this is great, right? Because it's simple. You can start with one tooth placement. I get this question a lot, like, why would you even consider it's just a simple surgery? You have teeth to guide you. It's a sad joke, right? But we don't want to touch any of the adjacent teeth. We don't want to become a root seeker as a dentist. That's always like a heart-wrenching day in the office. If you've ever witnessed someone do it or had a patient come in, or you yourself have experienced getting too close to one of the patient's adjacent teeth, that's a really sad day. So guided surgery, you can plan all of this ahead of time, and you can really minimize all these potential risks and make that place that implant in the precise location. So even for single units, I love using my surgical guides. For mucosa supported surgical guides, so this is where I'm hit or miss on these. Okay, so I know a lot of doctors like doing this because they don't like the idea of laying a flap. But when you get into surgery like this, you have to get comfortable laying flaps, right? Because things go wrong sometimes, and you have to be able to deal with some of the complications that come along with this. So you cannot get into fully guided surgery if you're not comfortable laying flaps. I'm just going to say it right then and there. So a lot of times what we see with these mucosa-borne guides, these are probably the least accurate. And that's really because it's going to depend on the resiliency of the soft tissue underneath it, right? So if you're planning a surgical guide at mucosal level, you better make sure that that tissue does not have any bounce to it. So when you position that surgical guide, depending on how much pressure you're putting on it, you can vastly change the position of those implants. So you really have to be mindful of what the shape of the soft tissue is underlying those. All right. But these sit on the soft tissue. You can anchor these in place. You see these little silver pins sticking out the side. These are called anchor pins for those that are not familiar. So this helps anchor the guide too. So the tooth-borne sits on top of the teeth. That's what anchors it in place. These are held together by these pins that go laterally that help the guide from not moving around while you are drilling the osteotomies. Our last type of guides are going to be these bone supported guides. So this is a guide where you have to open up the tissue. This sits on the bone. And so the stability and the accuracy of these is really going to be dependent on the alveolar ridge itself. So bone density, nice dense bone is obviously going to be easier to view on the planning software. The guide is going to be much more accurate, much easier to seat. All right, so these are going to rely on the bone as well as those anchor pins going through the laterally to help support and prevent that from moving around during surgery. So if you want to step it up a notch even more, for those of you that may be doing like full arch, maybe an immediate load type situation, now companies, including Glidewell, they're starting to do these stackable guides. I know Dr. Resnick has come on here and both Dr. Resnick have come on here and talked about things like this. Right. So there's ample opportunity to do everything from a single unit all the way to a full arch using guided surgery. So really the sky's the limit. It just really depends on your comfort zone. But I do think if you want to get into placing implants, or if your surgeon is doing this as the restorative doctor, this is a very predictable way to get restorative outcomes. So again, a little more work up front, but at the end of the day, it makes my restorative journey so much easier. And so I just want to talk to you a little bit about starting one of these cases, right? So starting a guided surgery case, I keep talking about restorative, right? So if you've heard me lecture, you've heard me say this phrase of top-down treatment planning. And I am a big believer in this, right? So Nicole mentioned I'm a prosthodontist, I'm a restorative doctor. At my core, I like to have a really good understanding of where I'm going to end up at the end of the day and maybe what roadblocks I'm going to encounter, right? I want to have those conversations, those hard conversations with my patient before I touch them. I don't want to make excuses for what I've done. And it might not be what I've done, right? I might not have recognized something right away, but I would rather understand all those complications that I may run across beforehand and have those hard conversations with the patient up front. They're much more understanding when one of those complications comes about, right? So it's all about having that shared goal, that shared journey with our patients, and kind of having them be a part of the process, right? They'll be much more understanding and much more willing to kind of work with you when things maybe don't go exactly as you want them to, or when you know they're not going to go exactly as the patient wants them, they'll understand that journey a little better. Okay, so we have three basic types of patients. I'm kind of simplifying this as much as I can, but we have three basic types of patients when it comes to surgical guides, right? So we have our dentate patients, so patients that have a majority of their teeth, you're maybe only replacing like a single implant or a single site. right? One or two. Then we have our partially edentulous patients. These are patients that potentially you don't really have any posterior support, right? So they're missing a large number of teeth, but they still have some teeth. Most of these patients have teeth in the aesthetic zone that they're not really willing to part with right away, right? Until you do some sort of surgical workup. And then we have our fully edentulous patients. So it's a rare occasion, but it happens. A patient might come in without anything, right? But most of the time they're coming in with some sort of denture or prosthesis, whether or not they're wearing it, that's another story, but they typically have some sort of teeth that they're going about their everyday life with. All right, so these are the three categories. So for each of these types of patients, there are basic records that I like to take. So regardless of the patients, I like to take out my intraoral scanner. So you can do traditional impressions if you don't have a scanner. I'll kind of go over some of the advantages that I like with my intraoral scanner that traditional impressions don't afford me to, especially when I get into some of these bigger style cases, right? And then also our CBCT. So I mentioned if you're using panoramic images or 2D images to plan and place your implants, I urge you not to do that anymore. The law will not really be on your side if something does go wrong. CBCT images, you don't necessarily have to have one in your own practice. There's mobile CBCT clinics now. There's clinics and the imaging centers that you can send your patient to. So really, really advise you to use a CBCT image for your planning. So certainly if you're doing guided surgery, you will need that 3D image in order to plan and fabricate your surgical guide. Okay, so through Glidewell, Nicole mentioned I helped to kind of create some protocols for the lab. We're updating and constantly trying to work on some of these as we move through. So this was something that we did last year. So for each category of these, there's a nice step-by-step of patient records. So when the patient comes in, exactly what the lab will need from you in order to help you execute and fabricate your surgical plan and guide. So this is good whether you want to do this on your own or use the lab. These are still the same steps that I require when I'm planning and fabricating my surgical guides. So I'm going to capture basic photographs, right? So whether it's a single tooth or a full mouth, maybe with the exception of like a posterior non-aesthetic zone tooth, I want to know where the patient's lip line is. I love photographs for the main reason that when a patient goes away, and they were like the first patient I saw in a day of maybe, 10 patients or so or more. Some people have like really busy practices, right? See a lot of patients in a day. By the end of the day at 5 o'clock at night, when I'm writing my notes and submitting my scripts to the lab, I don't always remember their smile line or everything, right? So photos help jog my memory and help me really plan out accordingly what I want to do, and helps the lab tremendously in helping you plan a more desirable outcome. So photographs are good. You can snap them on your camera. You don't need a fancy camera to do this. You can snap them on your iPhone rather, or your smartphone, whatever you want to do. And then impressions. So I mentioned you could do physical impressions or digital impressions, but really important, especially as you get into the bigger cases, you want to make sure you get all your landmarks. You want to make sure your bite is accurate, that you're taking. For these cases, for dentate cases, I like to do maximum intercuspation for the patient. And then I'm going to just say this, but you want to make sure that if you are planning on doing any clear aligner therapy or orthodontic tooth movement on this patient, you do it before the implant is placed. I do see a lot of doctors placing implants prior to tooth movement. You want to remember, implants don't move like teeth. So they are ankylosed into the bone. So you want to make sure you're moving your teeth around first, and then you want to get that patient into MI, that maximum intercuspation bite registration that you're going to send to the lab. All right, then on top of that, you're going to take a CBCT image. So the lab may request, and they do request, an open bite CBCT. So that means if you have a CBCT scanner in your office, they're going to bite down on that little bite tab. So this just separates the teeth just a little bit And it gives this ensures that if for whatever reason they have existing restorations or other maybe things like screws or something in their mouth that's going to kind of cause some radio opacities or reflective surfaces, it's going to give more clarity to the teeth and separation of the arches, making it easier for the team to plan for you. Okay, so when we get into the planning phase, even for dentate cases, they do this digital wax up. So they give you an idea of what this tooth is going to look like. Many years ago, when I would do, even when I would do like my pilot guides, I would manually wax up a tooth in this edentulous site, do like a suck down, do my pilot hole. And this is kind of, I would hope and pray that I would get the angulation of my drill in the right orientation, right? So I don't become one of those root seekers. I don't want to seek out the adjacent teeth. So here we can fully plan in that digital world, a digital wax up, and then the implant position is based on that tooth position, right? So we have the ability of moving the implant around. We can see, so here you can see that orange or yellow rectangle, the circle in the middle picture, that is representation of your access channel, the long axis of the implant. So you can see exactly where that's coming through on the tooth to ensure that not only are you in the right orientation, but you're coming exactly through that central fossa if you desire that screw retain restoration. So this was a case that came to me just recently, case from the outside, right? So this was placed many years ago. These are old, the Nobel Trilobe implants, but these, right, you could see not ideally placed. I'm going to say this is another one that was done freehand. And this is a case where every couple years, this patient's restorations come loose. So if I were to redo this today, this is more ideally where I would try to place those implants. And I love this because we can have this conversation with the patient. So what if, worst case scenario, that was the best position that we could have placed those implants? I can have that conversation up front with the patient and let them know all the complications that I know are going to happen for the rest of that patient's life with that style restoration. And I can let them know, based on this, I think it's really important that we do additional bone grafting and take the time to do additional maybe bone and soft tissue grafting to get the implants in the correct orientation. Or if the patient's not interested, as the restorative doctor and someone that's probably going to be married to this patient for a long time, you may decline to do the case, right? It's not worth that little monetary value now for a lifetime of frustration with that patient. So it gives you that opportunity to kind of go back and forth with the patient and make sure you guys are on the same page. We're married to these patients for a long time. You have to have an open and honest relationship with them. Okay. So for the next set of category, we have our partially dentate patients. So a lot of times with these patients, they're lacking that posterior support. So I mentioned before, so similar records, right? We still want our photographs, we still want our impressions, we still want our open bite CBCT, all for the same reasons. Where this gets me, where I lean towards more of a intraoral scanner for these patients versus a traditional impression is one, maybe some of these teeth may be a little bit more loose, right? So that's a very easy intraoral scan. I don't want to extract any unnecessary teeth. But the other thing that I find easier is what if they have no posterior support? So when you take traditional impressions, now I need to pour those impressions, get some sort of wax rim or some sort of stability, like make a partial something to help stabilize that posterior segment. So when I send it to the lab, they're able to tripod and mount the models accordingly. So in a digital world, we don't need that, right? You just need some of the opposing gingival tissue in order for the scanner to take that scan. So if you have an intraoral scan in your office, great. If you don't, this is another benefit of maybe trying to go that route. So really, really helpful when we get into these. We don't need to take that extra appointment to get these records. But yes, so you want to make sure you're capturing their vertical, the correct vertical. So for these patients, if they really don't have a lot of bite, I like to put them into a CR position, right? If they don't have that repeatable bite, I put them into some CR position. before taking the bite. With a scanner, I do like to stabilize that. So I will put just like a little bit of PVS between the anterior teeth if they have them, or some sort of stop position to help and prevent their jaw from moving as I scan from one side to the other. So this is helpful. Another thing that I like to do for this record. So for a lot of these patients, if I'm replacing just some posterior teeth, not a big deal. I can leave it alone. I know. But if this is going to be a case where I'm doing like a full mouth rehab, and I may want to see if I'm moving a lot of, extracting a lot of teeth in the end, or I may want to use this patient for a full arch of implants, that's how many teeth are coming out, then it's really important that I want to take this record, this bite record, in kind of a true vertical dimension. So this is much easier when the patient is over closed. So if you have kind of a shorter starting point for your vertical dimension, I like to use aesthetics as a starting point to open up the vertical dimension. This is very easily done in a scanner, right? So same way, open it up aesthetically where I like it, put a little bite registration holding that open vertical, and then I can take an open bite. I have to tell the lab I'm doing that, right? Otherwise, they're just going to think you took the bite in a funky manner and they may try to close it down on you, right? So you have to communicate some of those things, or it will either elicit a phone call or an improper record intake on their end. Okay. So like a situation like this where I didn't really have the full 3 stops. So remember, in order for them to manually physically mount something, you need a tripod. So you need some sort of anterior stop and then at least one stop in each posterior segment for them to be able to accurately mount something. So if I was doing a traditional workflow in this case, I would have to get some sort of bite rim in order to take that bite registration and send it to the lab. Okay, so for your edentulous cases, there is a slightly different workflow involved. And so with this workflow, it's typically going to involve the denture. So we still take our photographs. So I like to take my photographs with the patient's denture in place, right? So these photographs, again, I want to relate the face to the teeth. That's the most important part. So I want to make sure I understand where that smile line is in relation to the actual tooth position that I have created. So for me, if I have a patient that is in a denture or that I think I'm edentulating and I don't have a good aesthetic starting point, I like to create one. So either I'm going to remake their denture, could do like a printed denture, something quick just to get those teeth in a more relatable position. Or if it's a denture that's pretty just worn down, but the general tooth position is good, I'm okay with that. But the biggest thing with this is you want to make sure the denture itself is well seating. So if it's really loose on the soft tissue, you have to reline the denture with something. Soft reline material, there's a list of recommendations kind of on the website. A lot of labs will tell you what you can and can't reline with, depending on what software they're using, but you want to make sure you're not relining it with something that's not going to show up radiographically. This gets a little confusing, but I'll try to just simplify it. So the denture itself is going to be kind of a basis for how they're going to set up your surgical guide. So especially if you're doing a tissue-borne surgical guide with something like this, really, really important that that denture seats very evenly over that soft tissue. So we take our photos, we use our intraoral scanner, we take a physical impression of the dentures themselves. So I don't need to go into the patient's mouth necessarily and scan the soft tissue. You can capture that by just scanning the denture 360. I've seen a lot of people lecture and companies talk about just hand articulating the dentures. So I don't like to do that because I think there's too much wiggle room, especially if patient's been wearing the denture for a long time. There might be some like wear patterns in it. So I always put the dentures into the patient's mouth, make sure they're seated, and then guide them into that bite, the desired bite that I'd like them to be in, or the bite, their habitual bite that they're comfortable in. Okay. But I want to make sure they're biting. And then I do capture that bite intraorally. As far as the CBCT scan, so this is where this totally differs from the other two workflows. So for this, we want to do something called a dual scan. And so a dual scan is something where you're actually going to scan the denture themselves. So we put these markers, put these little markers, we call them fiduciary markers, markers on the denture. We scan the denture himself. So that's one scan. And then the second scan is we scan the denture in the patient's mouth. We do this because the patient's bone and the denture are two very vastly different radio densities. Okay. And when we go to plan, we can then use the teeth and the dentures, just like we did with that diagnostic or digital wax up, to plan our implant placement, our abutment placement, all of that. Right. So this is really, really important. So I want to just take a few moments to discuss some principles of the actual implant placement. So the first thing I want to touch on is the distance between the tooth and the implant. So for blood supply of soft tissue, for risk of surgical harm, we like to be about 1.5 millimeters from the adjacent teeth. So that's from the platform of the implant to the outside diameter of the implant to the adjacent tooth, 1.5 millimeters. And then we want, for myself, I like to think about where I am in the mouth and kind of the size of the implant that I'm utilizing. So I do not want to use a 3.0 or a 3.5 millimeter implant to replace a single molar tooth, right? That's not equivalent. So I always like to look at kind of what diameter tooth I'm replacing, and that should be similar in size to or closer in size to the implant that I am replacing it with. All right. So as close as I can. So for the Glidewell HT, this is kind of what I like to do, right? So for my 3.0s, I'm doing maybe mandibular anteriors, my maxillary lateral incisors. And then as I get into my 3.5s and 4.3s, I'm doing premolars, my centrals, my canines. And then as I get into the posterior region, I'm looking at more of the wider implants, the 5.0s and the 7.0s to replace those. So I want that larger diameter implant to help distribute those forces more favorably. And this even goes when I'm splinting things together. I still like those larger implants. If I have to place multiple implants next to each other, you want to make sure you're placing them about 3 millimeters apart from each other. So this helps to prevent angular defects that you may get from converting into big like horizontal defects. Yes, so sorry, it's just not moving forward. There we go. All right. So the other thing I like to look at is my buccal bone thickness. So when we take those initial intraoral scans, it gives me the opportunity to discuss all this with the patient. So we look at this image on the left, we see that there is we call this like a catcher's mitt, a nice buccal defect that has been created from the patient missing that tooth. So this is something that we went ahead and we did a ridge augmentation. So this took a little extra time, right? But the patient understands why we're doing it. We're having this discussion. So I like to have at least 2 millimeters of buccal bone thickness on my implants. So a lot of studies have shown that kind of less than this, we're more apt to lose that buccal plate over time. All right. I also am going to take a moment. The intraoral scans are great because sometimes that's really hard for me to visualize this in the mouth. I like to look at the adjacent teeth. So I like to evaluate the angulation of those adjacent teeth in relation to what I imagine the restoration is going to look like. So my main thing, I want to avoid black triangles. So that may mean I have to have a conversation with the patient that we may need to do a little enamelplasty on the adjacent teeth, or we may need to do a little pre-ortho to get these teeth in a better situation to prevent some of these black triangles. Because there's a lot of studies that have come out that show adjacent to our tooth-bound implants, we're seeing a lot of recurrent caries. And that's really because we have these unfavorable areas where maybe our papilla aren't there anymore and we're just packing food in there. So I really want to minimize those black triangles as much as I can. As far as the opposing tooth, really important. Take a look at this. I have these conversations up front, especially the patient on the right? Hey, you have a tooth. Over time, this happens a lot with these areas. The teeth seem to drift down. So we have to either through ortho, push this tooth back up, or if they don't want to do that, we have to talk about other means of either intruding or taking away tooth structure to level out that plane and give us a more favorable occlusal plane, and most importantly, room for the restoration that we're trying to build, right? So I just want to run through a couple, maybe one case here. So just an example of how easy this surgical guide situation can be, right? So this is a case, this is a healed site. So easy situation if you're getting into this, right? So we go through, we plan. This is kind of the plan that comes back, right? So we can see exactly buccolingually where we are. This kind of green halo around the implant, that's what we consider our safety zone. So a lot of softwares automatically default to about 1.5 millimeters on each side, 2 millimeters on the apex, and that's to make up for each drill usually has an extra like 0.5 millimeter on the tip of the drill, and that's to help make up for that. So we're getting that 1.5 safety zone all the way around to help us avoid any vital structures. It helps us measure buccolingually how much bone we may have. Stay away from those vital organs. And we can look at the depth. So for me, when I look at the depth of the implant, my goal is to put the implant about 3 millimeters apical to the adjacent CEJ. So I'm looking, for most of my cases, I'm looking at the buccal CEJ, which is typically lower than the interproximal. And this is making sure that I have enough room to properly contour my restoration, right? So for this particular case, we wound up placing, based on the surgical plan, we had this all planned ahead of time, a 3.5 Glidewell HT by 8 millimeters, because that's what we had room to do. All right, so these are the drills. So at the end of the day, these are the drills I'm running through. So each drill has, in fully guided system, has a barrel that's going to engage the drill, the guide sleeve in the guide. And then this particular system has a drill stop that allows me or the clinician to fully seat that drill without much thought and like visual cue, right? So this is the guide itself. So that barrel engages that guide perfectly. That internal portion of that guide sleeve is that same shape as the drill barrel. And you can see when we put it in, there's only one way we can put it in, and we bottom it out on the guide. And so this can make for a very quick osteotomy prep, right? I'm not stopping in between each drill to take radiographs. We've already planned it out ahead of time. I'm very confident that when we finalize this prep, this is what the implant is going to look like. And then exactly where I planned, that yellow hole in the middle is where I plan that access channel to be. And it's hard to see on the slide, but that's exactly where my access channel is on this implant restoration. Okay. So I want to talk just a little bit about kind of some of the other advantages, right? So not only can we improve the position, but then we can also create custom provisionals, custom restorations at the time of surgery. So huge advantage of guided surgery. So we can create custom healing abutments. We can create custom, if this goes forward, custom provisional restorations, right? And then the biggest pull for me is I know ahead of time I can have this discussion with the patient what the restoration is going to be, right? So I have sometimes where I'm limited by the anatomy, no matter what I do. This is going to be a cement retained restoration. So I know this because the access channel is coming through the incisal edge. And so I can have that conversation up front with the patient. If there is something you can do, like additional grafting, this might encourage the patient to go ahead and do that extra step and do that extra surgery, because you can explain the downfalls of cement retained restorations, right? So nowadays we all prefer these screw retained restorations. So this is a huge advantage of guided surgery. It gives you that opportunity to have those conversations before you touch the patient. So quickly want to touch on vertical dimension of occlusion. So like restorative space. Okay, so remember, screw retained restorations require less room. So cement retained restorations require more room, right? So just a quick little visual. So we all have our like retention form, right, of the abutment. If we ever prep a tooth, or resistance retention form, right? when we're cementing something on needs to be such. So that is pre-planned in the abutment height. But what we have to account for with our cement retain restorations is the placement of the margin. And so that's going to really depend on the depth of the gingiva. So sometimes we have really shallow gingiva, sometimes we have really thick gingiva. We have to bring that margin up either equigingival or just subgingival. There's been so many studies that show when you do these stock abutments where the margin is way below the soft tissue, you are leaving behind cement. No matter what technique you use, what you are doing, I've done it even with the best techniques, you leave cement behind. Okay, it's just studies have shown it time and time again. There's been hundreds of papers published on it. So you want to make sure when you are doing cement retain restorations that you're using custom abutments or you're customizing your abutments to make sure that the margin is equigingival. In the aesthetic zones, I would not go more than maybe a 0.5 millimeter below the gingival margin if you need to hide it, because you are going to leave cement behind otherwise. So I love guided surgery because that space is planned from the beginning. It's planned from the platform of the implant to the opposing, and you can see that space from the get-go, right? Even when we're doing full arch guided, you can plan your abutments, you can plan your restoration. You know exactly how much restorative room you have based off that denture tooth setup, based off that digital wax up, based off of whatever abutments you choose to plan in the software. Like all of this is planned out. So you know exactly when you're placing your implants, you're not going to have that, oh shit moment when you go to restore, right? It's very comforting. I know exactly where I'm going to be. I threw this in here because people would love to take pictures of the slide, but depending on what you're restoring, there are different space requirements. So again, these are minimal space requirements. So this is like what the material needs to not fracture. This does not mean this is going to look good in your patient's face. So you want to make sure that, yes, you're abiding by these rules, but that you also look at what size tooth does the patient have that I'm replacing, right? I don't want to, if they have a 8 millimeter tall molar, I'm not giving them a 4 millimeter tall molar, right? I want to make sure I'm enamelplasting that opposing tooth to make it look like it fits into the arch. Okay, so all of that in summary, I just want to say, so I think guided surgery is great because it really does save chair time. So you can really maximize your chair time. Yes, it does require planning ahead of time, but at the end of the day, the amount of chair time it has saved me is huge. So not only in surgical time, but in restorative planning and in follow-up emergency appointments and complications prosthetically that may happen down the road, it saves me infinitely in chair time. So yes, the guide may be a little bit more pricey up front, but it is definitely worth it down the road. As far as accuracy goes, I place a lot of implants freehand. I still think I can get much more accurate placement with my guides, even when I'm doing single unit restorations. Much faster, much quicker. And for me as a restorative doctor, much more predictable restorations come out of these when we do them guided. It was a lot to cover today. So thank you for hanging in. I am here if you have any questions. If you think of anything later and you want to chat, have any questions, you can reach out to Nicole or reach out to me directly. I'm happy to help and answer any questions you guys have.
Great. Thank you so much, Dr. Manalili. Actually, your
You're
last
welcome.
comment brings up a question. Somebody was a little concerned about the accuracy. Like some studies show that maybe the guided can be off like about 1 millimeter.
Yeah.
And so they wanted to know what your thoughts were on placing flapless implant placement in the aesthetic zone over guided. But it sounds like you kind of
So,
prefer.
regardless, a couple things here, right? So I do love to do guided surgery. So in the aesthetic zone, if I have stable teeth, so there's a couple of factors, right? So if the teeth are moving, I have fremonite, like I'm worried that maybe my impression wasn't accurate, or if I put pressure on the teeth, because as you use the surgical guide, you do have to put some pressure on it to hold it in place. So if I'm worried is as I'm putting pressure on it, If things are moving, then no, that's probably not a situation where you want to rely on a surgical guide. However, if the teeth are stable, the bone is stable, um, I think this is a very accurate, nice way of doing it. So as far as flapless versus flapping, I didn't show an example of this today because we have limited time, but I do flap and do flapless with guided surgery. So with guided surgery, you can still, the surgical kit comes with like a tissue punch, so you don't have to flap. But like I said earlier, I love doing flapped surgery. So it allows me to keep beautiful keratinized tissue. It allows me to do soft tissue grafting at the same time if I need to. It allows me to like visualize that bony anatomy like firsthand. So first and foremost, I come from freehand surgery, so I still like to see what I'm looking at. But at the same time, if you're in like a posterior situation where you have like ample keratinized tissue, no, I don't need to lay a flap every time. It's going to be much more comfortable for that patient. But yeah, in the aesthetic zone, if you want to shape and contour that soft tissue at the time of surgery, absolutely. I totally do full thickness flaps, lay them back. I do papilla sparing flaps with these guides. And you can easily do that. So we'll just lay it, pull it to the side, and seat the guide, and the guide will actually help hold the flap back while I'm doing the surgery. So very, very easy. I hope that answers your question. If it doesn't, reach out to me. But
I think you did answer it very well, but of course, I'm not the one who asked the question, so please let us know if that answered it. You have a lot of concise information for the guides. Are any of these guidelines available? I did put some in the chat, but if there's like, do you have any from your specific guidelines?
like references you're
Yes.
looking for? Yeah, I can get some references for you. Absolutely.
And then I can send them over.
Yeah.
All right, let's see. So you had a question, we had a question on if you take a CBC every time for an implant, and it sounds like for diagnostic and planning purposes, you definitely recommend it, and then
100%.
modality.
Yeah. Yeah. So 2Ds are great. They show, obviously, we use them every day, all the time. So they show very valuable information. But in an implant world, I like to know things in a 3D situation. So I want to know exactly how wide the ridge is. Are there any concavities in the ridge? Where did the adjacent roots go? Are there any interfering um, arteries that may be like an artery anomalies? Where is the in the lower, where is the inferior alveolar nerve going? Is it a high nerve? Is it a low nerve? On the maxilla, where's the sinus floor? It just gives me an idea of how to angle those implants to avoid all those structures, and to avoid any complications that I may not see. So the most common thing I see when people use 2D radiographs is actually perfing through one of the plates. So that's a big complication, like perfing through the lingual plate, a big one, especially on the mandible and the posterior. That's something I haven't seen that complication in a long time, but I used to see that more often when we relied on panoramics and 2D radiographs. So that's like not a good day in the office at all, because a major risk back there is death, right? So
Yeah,
you can get like major bleeding back there, and it can close the patient's airway. So posterior mandible, big spot where we used to get some of those complications, and I don't see them as much anymore.
great, thank you. I have a question on scanning a bite. So patient Dennis is asking if I scan the bite and the patient doesn't have enough teeth for a tripod contact, do they still need a wax rim for the bite?
So no. So if you're scanning the bite, as long as you can get the vertical correctly. So like I said, if you have some sort of area where you can stabilize it, I do like to use PVS, because when you're scanning, that was always my challenge, going from one side to the other, having them repeat that bite, especially with so little teeth. So I do like to lock them in. So I'll take like a little bit of PVS just in the anterior, have them bite, lock it in, and then I can go from one side to the other, like comfortably knowing they're not going to move on me. But no, so that intraoral scan will register the virtual bite registration. So you don't have to worry about making a wax rim or anything like that to get the bite registration.
Awesome.
And every lab is different. So, I'm just speaking like you shouldn't have to do this. Glidewell would not require you to do this, but other labs may have like their workflows that they do. But theoretically, that bite is captured with the intraoral scan.
Great. Thank you. So I have two questions on the case that you show with the lower right, where the first tooth was placed too distally and the crown kept coming off or it was loose. Would you recommend splinting the first molar implant crown to the second molar? Or would splinting have prevented that from happening?
So it actually was splinted together.
Ah,
So it definitely helps. And I've been in this situation before and I've done just that, right? Splinting them together does help, but over time, those long cantilevers do wear down on the components. So a couple things I recommend. So if you have situations like this, um, look at the size of the implant. So if it's especially a patient like new to your practice and you're taking on this complication, you have to charge appropriately, of course, but I always talk to the implants. I always look at the size of the implant. So if it's molar sites, even if you're splinting like multiple molars together, you don't want them to be like 3-5 size implants. Even if they're splinted together, it still doesn't make up for the surface area and the force factors that you're going to be putting on them. So I still like to see 5.0 or larger diameter implants in those sites, even when I'm splinting them together. So diameter, the obviously limiting cantilevers as much as you can. So yes, it helps, but I still see those complications come back. Maybe 4 or 5 years later, they're still causing issues. So I've had a couple cases recently where I've talked to doctors, shown or talked to the patients, shown them everything, and we wound up taking out some of the implants, grafting, and replacing in the correct location. Because once you explain kind of the long-term maintenance on some of these, and it comes out of their pocket, not my pocket, unless obviously I'm the one that placed the implants. But usually these cases are coming to me as like a last-ditch resort. The doctor doesn't want to deal with them anymore. So at that point, it's on the patient to pay for those restorations and anything that happen, especially if I'm recognizing some of the complications up front and tell them what's going on.
yeah.
Yeah.
Yeah, that makes sense. You actually answered the second question within that, so thank you.
You're welcome.
Are these surgical guides coming sterilized? Are they
So,
being sterilized?
so, so I do disinfect them. So I put them in a chlorhexidine bath. I leave them in that bath. We usually put it in before the patient gets in there. It's usually in the bath for about like 30 minutes to an hour before we're starting. But no, I do not put them through. There's different studies out there, but I'm not convinced yet. We've done our own testing, and the glue that holds the ring in, it's actually a study I'm working on now, but the glue that holds the ring in, it does tend to come out after the autoclave settings that we have in our practice. So I tend to just put these either in you could do isopropyl alcohol, that works really well. And it doesn't distort or affect the resin, or or you can do chlorhexidine. So
Okay,
either.
great. Thank you. So we're going to switch over to grafting for a question. How many millimeters of attached gingiva is required for you to do grafting?
So implant placement in general, so grafting and implant placement, I do like to have a minimum of 3 to 4 millimeters of keratinized tissue. So that's kind of my cutoff. I'll say 3 millimeters would be the low end. So if I'm tissue punching, I want to make sure that I have 3 millimeters of keratinized tissue on the side of it. So if I don't, then most likely what is going to happen is you are going to lose some keratinized tissue. So if you have a nice band of keratinized tissue around it, as that fills in, nice keratinized tissue will fill in. As I'm restoring that implant, that means I'm going to have a band of 3 to 4 millimeters of keratinized tissue around it, which will hold out pretty nicely. I know oral surgeons that I work with that every time they place an implant, they treat implants soft tissue grafting, and they're amping up their soft tissue keratinized volume with every single implant they place. And that just tells me over time, I mean, they place a lot more than I do, and that just tells me over time they've just seen a lot of complications with these. I'm sure anyone that's restored implants long term in your practice, you've seen some of them. I see them come through here long term from many years ago. the loss of some of that keratinized tissue and kind of the annoyance that it causes the patient and us as the doctor. So really make sure you have minimum 3 to 4 millimeters of keratinized tissue as we graft. So I like to use Oracell. So you can obviously use the patient's own tissue. You can do a palatal graft, things like that. But I like to use them. Nice to the patients. I hate that pizza burn feel. So I like to use Oracell in my practice. It's an acellular dermis matrix to help build up the keratinized tissue. And then from there, once you have ample keratinized tissue, then you can make sure you can do your hard tissue graft. So sometimes these grafting procedures take a long time because you have to do them in steps, right? So if you don't have ample keratinized tissue or the tissue is really friable, so even if it's non-keratinized tissue, sometimes you can do both at the same time. But sometimes that non-keratinized tissue is very friable, and you have to build up good tissue before you can do the good soft tissue before you can do the hard tissue. Sometimes you can get away with doing both at once. Sometimes you have great keratinized tissue and you can just build up the bone on its own. But these are all good things to kind of note as you're planning, and you can have those discussions with the patient. So that one case I showed you of the 2 millimeter buccal bone, that was a case where I had to do soft tissue grafting first. She had really thin keratinized tissue that even when I went to reflect that, it was very friable. So we had to build that up first. We let that heal for about 6 months, and then we went back in and did our bony buildup.
Yeah.
And
That
so,
circles back around to the top-down planning, just really making
yeah,
sure you can see everything and plan it properly.
exactly.
Awesome. Well, this was great. Thank you so much, Dr. Taylor. This
You're welcome. Thank you,
Manalili.
guys.
Yeah, we've had a lot of great questions. If you have any other questions, you can always email me. Next week, we will have Dr. Ben Moralia. He's going to be talking on the benefits of clear aligner therapy. So please be sure to join us here next
Love
week,
it.
same time, and we will see you later. Have a great weekend.